Welcome back, everyone. If I can ask you to please take your seats. Folks, I'm sorry to say this break is over. There will be other breaks. I need a champagne flute, if anyone has that noise on their iPhone, to bring us all back from break. I'm excited that there's so much effervescence in the room, but if everyone could settle into their seats, we have a very wonderful panel. One piece of housekeeping in my housekeeping list that I forgot to mention is if you could be so kind as to wait until you're holding a microphone or at a mic stand before you ask your question, that would be great. I want to ensure that our virtual participants have the benefit of your inquiries. So without further ado, I'm going to turn to our first panel that explores the history of crisis response and how we can use that history to inform the implementation and operation of 988. With that, Dan, I'll turn it over to you to introduce yourself and the esteemed panelists. Thank you.
Thank you so very much. I really do appreciate it. And good afternoon to our audience here in person as well as our virtual audience. And as we get ready to do the introductions, let me first start out by acknowledging Kabir. Thank you very much. In the opening, you talked about Otsuka and we are better together. This is an illustration of that. Thank you for setting the stage for us. And Bill, as you talked about, Dr. Carson, you talked about the Sozosei Foundation being conveners, a clearinghouse, a collaborator. I'd like to add one more C to that, community. And that's what we're seeing today, and that's what we're starting with today is community. So, and the last word is Sozosei. It means creativity. So that's what we're counting on from all of us to make a difference going forward is creativity. So thank you. I think it's all very appropriate. Mrs. Hall, Ton, to you and Alexis, thank you so very much for sharing Miles with us. In vulnerability, there is strength, but you're stronger than many of us to be able to continue to tell Miles' story. And the Miles Hall Crisis Hub is critically important. Thank you. And as I mentioned, community, let me also take a moment to recognize and thank the Executive Director of NAMI, Contra Costa. It's all about community. And Gigi Crowder, you've been there as I had lunch with Ton and Alexis today, and they talked about how you have been with them. It's all about family. It is all about community. So from our spirit to yours, thank you for doing that. And for those that understand that we are in an incredible art museum, let it not be lost on us that Miles was a self-taught musician. His 26th birthday would be the 15th of February. So let's keep him in mind as we look at 988. The last thing I want to mention in this is that as the story that Ton shared about Miles, she was also in a story that was titled, many of us read a story early this year, 5 moms whose sons were killed after they called 911 for help now live with the consequences of a failed mental health system that uses cops as a crutch. So I think that it's many moms in our communities and many families that are navigating this. And this is our opportunity to have an impact. Now let me get into introducing this incredible panel. And let me first say thank you for traveling far and long to get here. Dr. Rebecca Neusteter is the Executive Director of University of Chicago Health Lab and the Principal Investigator of Transforming 911. She came here from California. Dr. Eric Rafla-Yuan is with the American Psychiatric Association. He's currently the Jeanne Spurlock Congressional Fellow working with the U.S. House of Representatives in Washington. And Victor Armstrong is the Chief Health Equity Officer at the North Carolina Department of Human Services. And my name is Dan Gillison, and I'm the CEO for NAMI. And my opportunity here is to ask the questions and provoke the conversation. In terms of the virtual audience, if you would put your questions online, we will get to them at the wrap-up, but we wanted to make sure that you have that opportunity. And for our audience here in person, I'll repeat one thing in terms of the mics. We have this virtual audience, so some of you feel that we will be able able to hear you, but our virtual audience may not. So if you would just hang in there with us and wait for the mic, that would be greatly appreciated. And thanks for all of you all and all that you do. Now let's go into setting the stage. You know, for us to move forward with 988, we have to start by saying, well, what system do we have now? How long has it been around? What lessons could we learn from it? What worked, what didn't work? And that's 911. And who knows that here is Rebecca. So she's going to give us that background, and then we'll go to current state, and then we'll talk about future state. Rebecca?
Thank you. Thank you all so much for the opportunity to be here. It's really such beyond a privilege to be here, and thank you so much for sharing your story and for the courage that you've had to show up here today, and for all of the advocates and the scholars, the researchers, and the practitioners in this space. I just want to acknowledge that I've had personal and professional experiences with 911, although as a white woman, my experiences are different from that of others, and I think it's really important for me to acknowledge that, particularly as a white woman starting this conversation. And I apologize, I'm gonna have to look behind me because I don't have the slides in front of me. But I just wanna set the stage a little bit in terms of this conversation, because what we know and what we think about 988 is so much gonna be built off of our experiences and our understanding with 988. And 911 is a pretty old system in certain regards, but is also a fairly new system in other senses. The very first 911 call was placed in 1968. And I'll share a little bit about that history with you all because I think it's important as we start to ground ourselves. But I also want to honor that 911 offers an opportunity for healing and for care. And it really is, at its foundation, a promising system that can allow anyone, anywhere in this country to access care and services when they need. Just this morning, for those of you who followed our Sozosei rules and regulations and you applied for the app, the very first thing I saw when I woke up at 6:30 this morning as I was filling out the health app was to call 911 if I was not feeling well and I needed help. Right? I mean, so we think about 911 as just this constant presence in our lives, and in some ways that's good, and in some ways it's challenging. We really need to think about that. So as we think about the history of 911, it's hard to imagine history without a rotary telephone, right? Many folks, I think, don't even know how to use a rotary telephone. I was listening to an interview with Paul Thomas Anderson, a filmmaker who just made the movie Licorice Pizza, and he talked about actually having to teach the actors on that movie how to use the rotary telephone in a way that was convincing. But this indeed was the very first 911 call was made from this phone. And it's the red iconic telephone. And in another sort of relic of history, this first 911 call was made in Haleyville, Alabama. And like so many historic sites in Alabama, we see these placards with the Alabama state flag, which of course has history embedded directly into the flag and the relics of slavery and the Confederacy. But what we read in this plaque is that the first call was made in 1968 from a congressman who answered the phone in the Haleyville police station. What we don't see about this famous February 16th, 1968 call was some of the impetus that led up to it. And so for some of you, you may recognize that really famous figure in the middle. That's Bull Connor. And Bull Connor, as we well know, was the director of public safety in Montgomery, Alabama, was very involved in the surveillance and really the intimidation and the terrorism of Black people, mobilizers across Alabama, was the archetype who basically led the Children's Crusade, which essentially, leashed dogs and fire hoses on 12 and 13-year-old, mostly mostly boys who were seeking the opportunity to go to integrated schools. So Bull Connor has this very, very interesting history where even the United States Park Department under Trump described Bull Connor as a white supremacist. So I think that it's pretty safe to say that it's not controversial that Bull Connor is a white supremacist. And he was at the center of 911 being developed in this first phone call that was made in Haleyville, Alabama. And the sort of rest of this story is, many of you may be familiar with the Kerner Commission. The Kerner Commission was launched after almost 160 protests in the summer of 1967, a summer that was not so dissimilar from the summer of 2020. The Kerner Commission's most remembered for condemning white Americans' racism as the cause of these protests, and that we really needed to have investment in Black communities and action against discrimination, jobs, housing. However, unfortunately, these findings were suppressed, and the staff of over 120 people who put together this pretty remarkable report were pretty much all fired. And despite them sort of arguing that the protests were a logical and effective political response to white supremacy, there was a lot of internal disagreement on the best approach to respond to this civil disorder. And what we often don't hear, however, is that there was a supplement to the Kerner report. And so while most of the recommendations that were presented in the Kerner Commission unfortunately did not go forward and represent the state of Black communities today that do not have the investment that they deserve, there was one supplement that is not often printed in the Kerner Commission, and that's the supplement on control and disorder. And this supplement actually focused on a set of policy conditions and proposals that were on the other end of the spectrum. It focused on expanding police capacity in order to suppress protests. It focused on giving government block grants that still exist today in order to support riot control and training and equipment. And it also supported this notion of infiltrating Black communities and movement spaces with undercover police officers in order to serve as informants. But this supplement also offered a universal hotline, an emergency services number, in order to help encourage police response in a unified and quick manner. So while the inception of one emergency crisis phone number had been proposed in the past, most going back most to fire departments, it wasn't until this supplement on control and disorder that President Johnson actually put 911 in place. And there were early concerns. Right off the bat, people described the fact that while 911 would be helpful in terms of accessing emergency services and decreasing response times, that it would also likely increase arrests and provide a more immediate solution to civil unrest, even if enforcement was not the best cause. And we saw this immediately. And one thing that I think is really important, particularly in context of the story that we've just heard and the stories that many of us are so familiar with, unfortunately, is that 911 made a concerted decision to couple care with enforcement. And so what that means is that families and friends and neighbors are in an untenable position constantly as to whether or not they should or can call 911 at fear that police will respond instead of others that may be better position to offer care. And this was actually the practice that was exactly adopted in New York City, which in 1968 was the largest police department as it is still today. And New York City adopted 911 initially just for police control and police response. So it shouldn't be surprising to us that 911 today really is associated with police being called much more so than care and other types of non-punitive responses. And so what we saw in 1968 in New York City was that half of the calls that were made to 911, even though 911 was only for the police, was for non-emergencies. And that's exactly the landscape that we see today. In fact, in many communities, it's as much as 75% or 80% of 911 calls that don't have to do with the police. So I just want to acknowledge my dear friend and colleague Katrina Feldkamp, who was very involved and instrumental in creating this research. And I want to acknowledge the real opportunity that we have for 911 and 988 to offer care, but also the warning of what history has laid out for us, that this system, which was introduced in 1968 and did not become national until 1999, still had this course. And so with the very quick adoption of 988, we're just months away from it being put in place across the country and being mandated everywhere overnight. We really want to pay close attention about how we can make sure that 988 indeed does provide care and that it doesn't have a disparate effect on communities, particularly communities of color. Thank you.
Thank you, Rebecca. With that history, and as we look at, you mentioned that it went national in 1999, so that's what, 21, 22 years ago. So what lessons learned could we have from the system as we look to develop this new system?
I think there are many lessons, and I think that the panelists here and those in the room probably have better ideas than I do. But I think to me the biggest challenge with 911 and 988 is that it's largely an unfunded mandate, and that we keep on replicating systems. For 911, for example, we have over 6,000 different 911 what we call public safety answering points or emergency communication centers across the country that each have their own separate databases and staff. And so it's incredibly costly, and it's not a system that today offers much in the way of support to its employees. So when we're thinking about wellness and mental health, it's actually really critically important that we focus on the wellness and the safety and the well-being of these call takers. About most of the 911 centers in this country right now are critically understaffed, some of them understaffed as much as 70%. Much of this is an artifact of the fact that there's been feminization in this field, and that 911 call takers are classified as secretarial or administrative agents. They don't actually fall under the public safety family. And so they're not treated well, and they have incredibly stressful jobs that they're expected to work 24 hours a day on holidays. And I think that that's a real lesson that we can learn from. And I really want to congratulate Sozosei and many other foundations across the country for trying to take that professionalization piece very seriously.
Thank you very much. And we're going to get ready to go to Eric. I had one more question when you mentioned professionalism. Was there any example of that recently in the George Floyd murder in terms of accessing 911? And if so, what was that?
Yeah, it's a great question. And two things that come to mind. I mean, first off, George Floyd was murdered by the police as the result of a 911 call. For what many of us would argue a non-criminal, very trivial offense, if it's even could be classified as an offense. And I think we really need to interrogate whether or not that made sense, and whether or not that was a good resource. And there were two factors at play. You have, most likely minimum wage employee who's working as a cash register in a convenience store, with the pressure that has for anyone trying to sort of make it in America on minimum wage. But you also have call takers who are watching in real time through closed circuit television as George Floyd was dying, and reaching out to sergeants and others in command within the Minneapolis Police Department and at the call center. And they were essentially the one call taker in particular who testified in George Floyd's the trial for George Floyd's murder, in painstaking detail about how she was trying to trigger the alarms, and they basically told her to stay in her place and not to worry about what was happening, which is obviously really problematic and troubling. Not to mention the fact that the George Floyd Act, which unfortunately we didn't see passage of, didn't mention 911 once. There was no reference to 911 or how the police were involved in that situation at all.
So as we look at a couple of things that were put on the parking lot, you mentioned 70% in terms of the workforce depletion. And what you've just shared is the lack of respect and acknowledgement of the role of the call taker in working in that PSAP, if you will. So with that said, Vic, I'll come to you first, and then Eric, I'll go to you. In terms of looking at equity, discrimination, racism, and equity going forward, what have you seen and what needs to happen for this to be very efficient?
That's a great question. I think, first of all, I think we have to acknowledge that we have an equity issue. And I think that's key to it, that we not just think about, whether it be 911 or 988, that we not just think about it in terms of this is the system that we have and this is the system that we work with. But I think we have to recognize that there is an issue of inequity, and there's inequity in a number of different ways. There's inequity, first of all, in the way that we respond to people who are experiencing mental health emergencies. And I do often share that I intentionally call them mental health emergencies rather than mental health crisis. And I do that because I believe that when someone is experiencing a medical emergency, we call it an emergency. When someone experiences a mental health emergency, we call it a crisis. And I believe that is in large part because we don't have the resources to meet that person at the point of their need, which means the system is in crisis. The individual is experiencing an emergency. But there's also a difference in the response and the resources when a person of color experiences a mental health emergency versus a white person. There's a very distinct difference in the response to a 35-year-old African-American male who is experiencing a psychotic episode or who is having a manic state or is suicidal, then the response would be for a 35-year-old white male who are experiencing the same thing. And so that tells me that there's inequity in the system. And you can look at the stats. First of all, for people who are killed by police, 23% of the people killed by police are said to have a mental health diagnosis at the time or be living with mental health challenges. And then black people are killed at twice the rate of white people in encounters with law enforcement. So that system and how we're responding to people experiencing that mental health emergency is not equitable. And I think in part that starts from the fact that it was not designed for or designed by the people that it's meant to treat. It was not created from the lens of people who experience mental health challenges, and it certainly was not created from the lens of people who experience inequity.
As you speak to the design and who it was designed for,
Yep.
How important is having lived experience as a part of the new design?
Yeah, I think that's extremely important because in any situation, you're talking about the intersectionality. So there's the intersectionality of being a person of color and experiencing a mental health emergency, the intersectionality of being a trans individual and experiencing a mental health challenge. So that intersectionality is extremely important. But I think also when we're talking about equity, if I'm looking at this from a health equity lens, the first thing I want to know if I'm creating anything to address health equity is what is the disparate need of the population that I'm trying to address. So I want to look first at, in communities of color, there's often not access to outpatient resources. And so if I don't have outpatient resources in my community, then oftentimes my interaction with the mental health system, that first interaction is either going to be in the back of a police car, in an acute care emergency department. At any rate, it's going to be when I am at that point of an emergency because I haven't had access to resources in the community where I live, work, play, and pray. And so first of all, I think you have to think about what is the disparate need of that population. The second thing that you have to look at is how do you create that synergy or the combination of that lived experience and evidence-based practice. So how do I make sure that I'm including the voice of the community that I'm trying to serve as I'm building those interventions? Because otherwise, you are going to miss meeting the need of that population. And I've often said to folks that we, even from a state system standpoint, we often think of things in aggregate numbers. So we create something that speaks to the most people, the most number of people, and you can create a resource or a system that might meet the needs of 80% of the population, and you still could miss 80% of the Latinx population. You could miss 80% of the Black population because you're talking about larger numbers rather than speaking to the nuances of race, culture, ethnicity, sexuality, of those kinds of things. So, and then the third thing I think you have to do is you have to look at how do you measure whether or not the resource you put in place is meeting the needs of that population served. So you would have to come at anything that you're building around 988 or any other system that you're building to respond to people experiencing mental health challenges, mental health emergencies. You have to look at whether or not it's going to meet the needs of that population that has been disproportionately impacted. So we want to decrease the number of Black and brown people who are dying at the hands of law enforcement. We want to decrease the number of people experiencing mental health challenges who are dying at the hands of law enforcement. We want to decrease the number of people experiencing mental health challenges who are getting a law enforcement response. And I think that is a challenge, in part because when I even think of my state, North Carolina, it is we have a lot of rural space in North Carolina, and in many of those rural spaces, there is a heavy reliance on a 911 response, a law enforcement response, and there's also a cultural reliance on a 911 response. I don't think that we can, as we're talking about equity, I don't think we can negate or ignore the fact that for many people, they want a response that is not designed necessarily to protect and nurture the person experiencing that mental health emergency. They want a response that's going to protect them from the person having that mental health emergency. And that's where I think we have a fundamental flaw in the way that our system is built. And if we're coming at it from a lens of equity, we have to start from the perspective of the people that we are trying to protect. And we need to be very clear that this system should be designed to protect and nurture the people experiencing the emergency first and foremost.
And not to protect the community from them.
Not to protect, and that's not to say that there are not situations where that's necessary. There are not situations where a law enforcement presence may be necessary, but we have to start from the perspective of a mental health emergency should have a mental health response. And if there then becomes an element of safety, then we build in that response of having that safety piece addressed, but that cannot be what you lead with. And by the same token, I think that part of our, one of the things that we have to be careful about as we're designing this is, I know that in a lot of states they're looking at a system where all calls go into one central location, then you make a decision. Is it law enforcement? Is it, mental health responders? But I have no confidence that Black and brown people won't still end up with a law enforcement response. And so I think that's the other thing we have to be very careful about.
And thank you very much on that. We'll come back to you, Rebecca, on that in a minute, so if you just file that away. We've got some things that we're putting in the parking lot in terms of outpatient resources in communities, professional staff, 70% gap in terms of available staff right now today. So these are some different things that we will make sure that we capture as opportunities as we go forward to create 988. Eric, and your body of work, your portfolio speaks for itself, both domestically and working in terms of in your discipline, but you've always been giving back in all the work you're doing, and now you're working on Capitol Hill. Tell us a little bit about the work you're doing now. I'd love for you to also take us back to the Ems Act of 1973, what you're seeing there, the legislation you're working on, and then lastly, Freedom House. So if you could just cover all that with us, that would be wonderful.
Sure, I'll try and wrap that all up. So, so a little bit of background. So I'm a psychiatrist and a public psychiatrist, and for a long time, the patients I worked with didn't have insurance or had insurance that covered them very minimally. And so when you have someone who's homeless and has been harassed by the police all week long, and you tell them, well, if you're having trouble, just call police and they'll help you, and they laugh at you because it's not a realistic answer. And so there are a lot of ways that this plays out. And so getting back to your first thing about in terms of policy, I think there's a lot of places where policy can play, and I think that Rebecca really highlighted that it's an unfunded mandate. And for this to be successful, we need investments, we need infrastructure, we need standards, because for a mental health response to be relied on both by the general public as well as law enforcement to feel that, well, we have other specialists who can take care of this well, and it's not necessarily something that we have to do all the time. There has to be standards, and there has to be an accepted reliance on that. Just like right now, there's a reliance on 911, and like you saw in the app, call 911 and 911 will come, and that's just sort of a public knowledge. And I think that sort of infiltrates a lot of American minds where they just feel like 911 has always been around and it's just a fabric of the United States. But so I think that the work about, well, it's actually fairly recent, and there's some reasons behind why it came to be how the way it is so important. I think another thing, too, that a lot of folks don't realize is how 911 for medical emergencies is also really fairly recent. And so a lot of detail behind some of this, but to make it short, in 1966, the National Academy of Sciences put together a report detailing the increasing number of American lives lost because they died before they could get to the hospital. The conception before this was that if you were sick or injured, you needed to get yourself to the hospital. And if you needed someone to get there, you could call police, you could call a service, but really it was police transporting you in a police car or a funeral home director transporting you in a hearse to the emergency room. And that's what it was, and there were an increasing number of people dying, a lot of them due to car accidents. And so the story of Freedom House, I think, is a really beautiful but also sad story. And so in 1960s Pittsburgh, in 1970s Pittsburgh, police just didn't respond to those calls for medical help when it came from black neighborhoods in Pittsburgh. And so the black community leaders in Pittsburgh put together their own community-led intervention. They partnered with the city and with medical doctors at the University of Pittsburgh, putting together what's now known as Freedom House. And so what Freedom House actually was a black community enterprise that was affiliated with the NAACP to help individuals in the community get jobs. And so when they partnered with the University of Pittsburgh on this, what they did was they trained previously unemployable, who were people who were on the street, young black men and women, to be what's now known as EMTs. But at the time, there weren't EMTs. And so they were trained in CPR, delivering medications on the scene, EKG, how to transport people safely, how to give a handoff in the emergency room to the physicians. And this was like brand new, because before there was just police dropping people off out of the backs of their cars. And so this really shocked the nation in how effective it was, and the model really took off really quickly. Something that happened after that is the model took off, and then the funding for Freedom House was cut off. And so I think that is a story about how we have to be very intentional about incorporating the community and not in a predatory way. So that was the story of Freedom House, and I think in some ways we are seeing that happen now, where communities, because the 911 or their other community leaders have failed them, are trying to put together their own community-led movements or programs to respond to mental health crises. And so I think that the Justice for Miles Hall is a great example of that. But I think for it to be a national system where people can rely and know that if I call 988, someone will answer, and if they're not able to handle on the phone, someone can come who is trained and who knows how to handle these types of situations. And if for whatever reason they can't handle it here at my house or wherever we are, there's somewhere that I can go to that's safe, and I can get help there. Mm-hmm. And right now we don't have that. And so I think that those are all really important things that we need to be talking about. And then one other thing, I think, as we get more into the weeds in the decision-making process, and someone had touched on this already, so being very intentionally anti-racist at each step of the process. Because if I call 988, but they say, well, that person sounds kind of dangerous, and so we're just going to shuffle your call over to 911. Well, what does dangerous even mean? And does that mean you're living in a certain part of town, or you come from a certain background, or there was a certain history? And so we really need to be thoughtful about this, because otherwise realize some of the 911 issues we could replicate with 988.
Thank you. It's a very, very good kind of a background. On the work that you're doing on the Hill, is there anything that you're specifically working on legislatively in terms of how are you navigating some of that in terms of your new work? And what are you seeing in terms of this situation here?
Yeah, so again, great question. I think that there has been, especially over the past 2 years, a lot of political momentum into what can we do to respond to mental health better and just mental health in general. One thing that I think that everyone, including policymakers, needs to be wary of, and I think that we also had touched on this a little bit earlier, so the current infrastructure to respond to a lot of this is 911 and police. And so there comes to a limit of, well, at some point we can't just train police to be better, you know? Like we can't expect police to be emergency medical workers and EMTs and social workers and mental health specialists and public safety officers and to be expert in all this and do it well all the time. And so we really need to make sure that we have specialists that are matched for the right job. And so I think that any legislation needs to take that into account. Specifically in terms of what I'm working on, so I'm in the office of Tony Cardenas, who's a congressman from Los Angeles, and he's planning to introduce a comprehensive piece of legislation on this. And so I'm excited to see that forward.
And thank you very much. And building on that, you know, we all ask ourselves what keeps us up at night. And so I'm going to ask all three of you, this is what keeps me up at night is looking at the workforce element of this, which is so critically important, and you've all hit on it in different ways. You just mentioned specialist. You mentioned 70% down, and also lack of professionalism. You talked about equity in terms of who's responding. So I want to ask this general question of all three of you, and it's again what keeps me up at night, and it's what's the best chance and the way forward in terms of how do we expedite the increase in this crisis workforce? What are your thoughts? So, no, we're not there.
To me, there is it's not a silver bullet, but there is something I think is low-hanging fruit, and that is lived experience. We have, if I use North Carolina as an example, we have some 4,000 trained certified peer specialists, and we have about 1,600 that are gainfully employed. If we could incorporate that voice of lived experience, because there's intersectionality in that voice. There are peers of all ages. That way we create a workforce that not only mirrors the color of the community that we're trying to serve, but you know, the same way there's a difference in 35-year-old black and 35-year-old white male experiencing a crisis or emergency, there's a difference in a 65-year-old and a 35-year-old. We can create peers that are also representative of the aging population. We can create peers that represent the LGBTQ population, and we can build those peers into our workforce because part of the challenge for many, and I think it also speaks to some of the challenges about getting people of color to access services, is I'm much less likely to access services when I don't see someone who looks like me. And a peer specialist may be the only person on the treatment team that looks like me. And I think we can embed that resource in our response, because not only does that give communities people as a part of that response team who look like the communities that they're serving, but there's also that element of lived experience, someone who can say, wait a minute, maybe if you just don't crowd this individual, give them some space to breathe, you know, they may respond differently. Or maybe think about, before you start you know, focusing on this piece of it, let's think about, do they have a place to live? Do they have food to eat? And so I think that's, to me, is one of the things that we can address relatively quickly, is embedding that voice of lived experience in our response.
Thank you. And you have an opportunity right there in North Carolina of 3,400 people or something like that in terms of bringing to the workforce. Eric, your thoughts, and then Rebecca.
Yeah, no, thanks. And also this reminded me, I left out one thing, which was the 1973 Ems Systems Act. So to make the EMS system functional now that we have today, it took an act of Congress to fund something. And so I think that is one difference between the 911 system there and the EMS system, the emergency medical response. Also attached to that came professional development and basically the creation of the EMT profession. And so right now we have folks who are able to relatively quickly after high school, either with college or without college, that can get professional qualifications as an EMT and serve as a first responder. But we don't have any ability for that for mental health emergencies. And so if the current model, it's probably the most popular model, is something where it uses a master's level clinician. But that's something that takes 4 years after, so 4 years of high school, 4 years of college, and then a 2-year master's degree. And that population right now is also, it does not really represent the communities that are hit hardest by police response. And so is it their room and the ability to develop similarly to how the EMT profession was developed after the EMS system came live, something like that where it's much faster for individuals to get training in behavioral health first response and open up a pathway for people to work in their own communities in that capacity.
Thank you. Rebecca, what are your thoughts in terms of workforce development? Thanks, Eric.
Yeah, I believe wholeheartedly in the recommendations that Vic and Eric have offered, and I know that there are many others. I'll just raise 3 points. I think, much of what they were discussing was in regards to response. So thinking about the 911 professionals and other individual professionals who will be answering calls on 988, which may in fact actually be 911 professionals, depending on the jurisdiction that you're in, at least for some time to come, if not permanently. But there are no national standards in terms of accreditation for call takers. And so, in some jurisdictions, you have to be able to walk somebody through CPR, and in some jurisdictions, there's literally no such requirement. So sort of thinking about what are the core competencies and requirements, what are sort of the model folks who essentially serve as emergency department triage nurses over the phone and need to be qualified and trained as such in order to figure out what the underlying causes and symptoms are to ensure that the right responder can indeed respond at the right time. And I would argue that that also may not be a field response, that we really should be leveraging the opportunity to do far more virtually and through telehealth options than we are today. The other thing that I'll add is that, while I'm a big believer and a recipient of the civil service system, and I think that there are really good reasons to make sure that there are civil service procedures in place and rooting out nepotism and things of the like, we've also created a really difficult system for people to get jobs that often don't pay very well and have a lot of occupational challenges. And so I think we really need to sort of think about that sort of feeder system. And then finally, I'll say I think we have this exceptional opportunity right now that we're looking at in terms of a crisis. But with crisis, there always is opportunity. And that in every single area, we are experiencing major vacancies. As I mentioned, there are major vacancies with 911 professionals and many of the other crisis hotlines, behavioral health specialists, law enforcement agencies. And so we have to really start to rethink who are going to fill these positions. And 5 years ago, we were having a different conversation about how do we pay for people to fill different positions. And right now, we're accruing lots of savings because all of these agencies are experiencing high levels of vacancies. And I think it offers a real opportunity to rethink what do we want this workforce to look like? Because we do have some funds, and we have the opportunity now with vacancies to really rebuild a different workforce.
Dan,
please.
I totally agree with that. I would also add that I think there are programs in communities that we could use as building blocks. Yeah. And I think that, while I'm a huge proponent of evidence-based practice, evidence-informed practices, but I think we also need to think about community-informed practices. There are communities that are doing things that are working. I've had folks approach me in the faith-based community and say, we want to be a part of the solution. What if we could do this, this, and this? And we're looking at models where we can put money in the communities at the ground level, work with community-based organizations to help to mitigate some of the challenges that we're facing. And it doesn't have to be And I think, to Rebecca's point, it doesn't have to be that they are the tip of the spear that responds when someone is in an emergency, but they also can be a part of helping to keep that person from getting to that point of having an emergency in the first place. And I think that's the piece that we have to build into our 988 process is how do we keep people from getting to that point of experiencing a mental health emergency? And I think that's where the community can be a huge part of that.
Thank you. That's excellent. As we look at this workforce, one of the things that I would mention to you is if you think about it, there's two places that we invest with our human capital, and that is as parents when we have that newborn that becomes a young infant and they're now old enough to go to daycare. So we send them to daycare and we write that check. The other place is in the behavioral health system in terms of being in that system. Those are two places where humans are being touched and their wages don't reflect what you're looking for in terms of the response. So we need to look at the wages for our behavioral health folks, just like we need to look at the wages of these folks that are taking care of our babies when we send them to daycare. Both of those need to be looked at. And in this mental health space, we need to look at, because we have, what you're talking about, Rebecca, is we have a back door that's wide open and everybody's leaving out of that back door. So how do we rethink, retention, and how do we rethink compensation and acknowledgement and support for them? And we know that being caretakers and being behavioral health supporters and workers, if you will, is very stressful and it's very hard work. So we need volume. And we need training, and we need some type of a certification. So I think that that's a way forward. And also, Vic, what you talked about is some of these community-based solutions, they're scalable. So we just have to have some proof sources and then see how we can scale it and replicate it in communities across the country. I'm anxious to see us do that. Vic, I've heard you speak about systematic and historic disparities as well as marginalized communities. Would you tell us more about these disparities and marginalized citizens in terms of your thoughts on that and what you're seeing?
Yeah, I think that probably the best example I could give outside of this specific conversation about 988 is to look at what we saw in early onset of the COVID pandemic. We saw very clearly where the disparities exist, because even when we recognized that there were disparities in the impact of the pandemic on Black and brown communities versus the white community, we didn't have the resources to respond, because we did not have resources that we could readily send into the community that were trusted resources, in large part because there's been historical racism and structuralism that's been built into our responses. 911 is an example of that, because people are going to be, and going back to the George Floyd incident, people are going to be hesitant. And I know people who are advocates in the behavioral health space who will tell people, don't call 911 because they're afraid of the outcome. So we know those disparities exist, but I think the way that we looked at mitigating those disparities in response to the COVID pandemic is three things. We looked at relationship, building those trusted relationships in communities, going into those communities, find out who are those trusted voices, and allow them to be a part of helping us to understand how best to address those communities. It was about access, creating more access to vaccines, more access to testing in those communities. We have to create more access in communities of color, in historically marginalized communities, to resources that mitigate mental health challenges. And then the third one is investment. We have to invest our resources in those communities, and that can look like a number of different things. I do think it can be putting resources on the ground in communities. I think it's also investing resources in providers, women-led organizations, Black and brown organizations in the community that have historically served historically marginalized communities without the benefit of government grants and resources. So we need to invest in those folks at the community level. And then also going back, I think, to the faith-based community. In Black and brown communities, the faith-based organizations have always been the gateway to the community. You want access into the Black community, go to the Black church. You want access to the Latinx community, go to the church, go to the mosque, go to the synagogue. We need to figure out how do we weave them into the processes to address the challenges that we have.
Thank you very much. As we now go to our questions, I wanted to just do a little gatekeeping here. Knowledge is power, using the history of 911, legacies of racism and discrimination, and lived experience to design for a better tomorrow. So that's what this panel is about. So now let's go, with that said, we'll go to a few questions. And instead of starting here in the room, if you all don't mind, we'll start with one of the virtual questions if everyone's okay. All right. Now, before I do that, let me ask the panelists, is there anything that you wanted to mention that's kind of like, aha, I meant to say this and didn't get an opportunity to? All right, well, we're good. Let's go with this first question then. What are the most critical build-out requirements that must be initiated now to ensure that communities can effectively launch 988 responses? And then the next part of that is, and what levels of state or county advocacy must we focus on in early 2022?
I'll start that one. So I think that something definitely needs to be done, and so I really appreciate this question. If we get to July and there isn't any federal action taken, what we're going to have is a patchwork of response systems. So in some states you call 988 and there's absolutely nothing there, just routes you to the suicide hotline or to 911, and it's as if the whole July 2022 didn't make much difference at all. In other states, maybe they have the full continuum of crisis services. And so we really need to see a federal response to have some sort of coordinated, reliable system. The other thing that I think that's important is starting to invest in community solutions. And for many years, police has been what's there, and so that's when politicians and elected officials want to make a difference, they say, okay, well, we'll give this grant to Department of Justice to fund police to do this thing better. And now we got to what we heard about the very intro, where it's in our prisons and jails and police departments where people get mental health help, and because there was nowhere to get it before. And so we really need to have an investment in that infrastructure. And the other thing I'll say is that advocacy at all levels of this is important, because even though we need federal resources, the people actually implementing it are at the state or county level, depending on where you live.
Anybody else want to handle this one? Thank you, Eric.
I would say similar to response before, and I think Eric touched on it. I think two of the components that we have to have are we have to have a response, an equitable response, when people experience those mental health emergencies. So you've got to have the resources in place so that people get a response that does not have to be a law enforcement response, and whole other story, but that response needs to look very different for children than it does for adults. But we've got to build out that response. But the other thing I think is we also need to be taking this opportunity to look at how we build out those resources in the community to keep people from getting to that point of emergency in the first place. Part of that, I think, is that we do need to look at what is the template for what a system of care needs to look like in a community. I think the closest thing we have to that may be CCBHCs, but we need to think about, how do we build that out in communities so that every community has the adequate resources, and what does that need to look like?
Thank you very much. Rebecca, did you want to weigh in on this?
I'll just add quickly, I know some of my colleagues here in the room, and with some support from Sozosei, are finding that many people across the country have not even heard of 988. So we've got a big road ahead in terms of educating people about this. But I would caution that we don't want to just educate people to learn to dial 988. We want to educate people in their communities to know who is behind the phone when you call 988, and are those responses the ones in which we want to see and that will have the equitable outcomes that communities deserve.
Yeah, speaking to this and this, the skill set of the person that takes that call, and as this second part of the question, and what levels of state or county advocacy must we focus on in early 2022, and what are the most critical build-out requirements? I think that what Sozosei is doing is the first part of it. We did a reimagine a week addressing mental health response. And we called it Reimagine, a new way forward in terms of response. And we did a poll that week, and we found that only 4% of Americans actually knew anything about 988. The other thing that we did is we had a state advocacy workshop where anyone that was from a state that wanted to learn how to advocate within their state we actually had tools and resources for them and an actual workshop. So it will take all of us, and it is about community, as Bill said at the very beginning of this. I think that answering the first part of it in terms of the build-out, it's leadership, it's tone, and it's execution. And the execution comes with the funding and all the other things. But if you don't have the leadership and the will and the tone, it ain't going to happen. I know that the proper English is it is not going to happen, but I'm going to say it ain't going to happen. Let's go to the next question. Is there a question here in the room before we go to the next one here? We have a question down front, Dr. Carson, but the mic is in the back, Doc. You can come up here if you want. Hold on a second. We're going to take Dr. Carson's question and then yours.
It's where you started, Dan. I think one of the things that we've talked about is not that industry is the standard, but if you were going to make this kind of change in any kind of company, we would be in the change management piece, not the decision part of the piece. So we are so far behind, and I don't want to throw the whole thing off that way, but the idea that in every state around the country, in every community around the country, when 988 happens and you flip the switch, that somebody's going to be their reliability answer. That's just not true. So I think what we have to really focus on is where is that happening, and at least be able to tell those communities what is it going to look like in your community and what do you do until that happens. So I guess my question is, how do we positively say what I just said? That's a really hard part, right? And then the next part is, how do we accurately say what is the state of the 988 system in your own community? That's the question, the true question.
Yeah, got it. So it's who wants to take it? It's kind of setting the right expectation in terms of what's not going to be on July 16th of 2022 versus what is, and then how can we scale it, and how do we run on parallel tracks to kind of augment what won't be there?
I'll start a little bit by saying that I don't know the full answer to that, and I think it's a complicated question. I use a little bit of the corollary of that, talking with some of my colleagues as I explain to them the importance of legislation on this, where I say, you know, folks in your state that you represent will not have access to anything else like this as folks in other states. But as to how to reach them, that I don't have a great answer on.
Yeah, what I would say is a couple of things. One is I think that while there is a consensus that we need to strike while the iron is hot, and I think we know that there's an appetite right now to move forward, and we don't want to miss this window of opportunity. But I think at the same time, we need to figure out how to slow this train down a little bit so that we can get it right, because we cannot assume that people at the community level even know what a system should look like. And so if we start talking about, you know, what people have or don't have in their states and their communities regarding 988, people only know what they've had. They don't know what they could have. And so I think we need to stop and slow it down, and even think about it in terms of the way that our system, our response system is built. We push people toward diagnosis. We push people toward crisis in order to get help. We need to take a step back, understand what do you want to happen when you are experiencing something that you just don't understand. When you look at your child and you say, Johnny's just not right, something's not right, what do you want to have happen? And that's what we need to be building to respond to what people want and need, not trying to just shift what we currently have so that we can fit people more squarely into the boxes that we've already designed for them.
Yeah, no, thank you for that question. I eagerly await to see what it looks like, and I hope that the answer is that it results in care and safety for everyone who needs it, whenever they need it, outside of business hours and outside of metropolitan cities, everything. But I would just take one other step to say, in many places, this is a far more localized conversation than even at the state. People are working hard and really trying to figure this stuff out. And I think there are not a lot of great models, and the time pressure is real. And I think that's difficult. I appreciate spaces like this, and I give the states and the localities that are really banding together to try to understand how are they going to collect the revenues that they need, and how are they going to ensure that the states actually give them the revenues that are collected for what they're intended to be used for, because that's not actually the reality in the 911 system today.
Yeah, we got to get it right. In terms of getting it right, to you all's point, it can't be tactical or transactional. It's got to be strategic. It's got to be well thought out. And we've also got to come to terms with what won't be, and us running on parallel tracks, meaning we can't move away from CIT and say CIT that we're going to stop. We've got to, because there's no way for us to do this well and have it pervasively across all communities in July 16th of 2022. So we have to do both and, Bill, I think. Time for two questions. We have one in the back and then yours down front. Yep.
Thank you. I have a question that touches on some of the points that were made about how do we best represent the members of our communities that are diverse, and talking about inclusion. And so one thing that I haven't heard about is how do we also include all of the language differences of our community members? We have here in Philadelphia a growing immigrant and refugee community, and unfortunately we find that language access continues to be a very, very big problem, and one that has a lot of consequences. Thank you.
Vic, you want to start us with that one?
Sure, yeah.
Thank you for the question.
And yeah, thank you for that question, because I do think that that is one of the things we have to address is language issues. It's also issues for people who are deaf and hard of hearing, people who are visually impaired. All of those things I think have to be factored into it. And I think, again, for me, it starts with having folks at the table who can speak to those challenges and adding that voice, making sure that we have representation from those communities. It doesn't necessarily mean that it's the folks that are always at the table either. It is going into the community and finding those trusted voices and bringing them to the table. But I definitely think language access is something that needs to be addressed.
Okay, thank you very much. Anyone else?
One thing I could add, just like very practically and logistically, so some of you may be aware that the FCC recently approved the texting portion for 988. And so working with that to make sure that the texting is also available in other languages, even if the voice isn't always.
Okay. Well, one last question and then we'll wrap up.
It's both a comment and a question. I so appreciate everything you said. We're in Contra Costa County in California, and because of what happened with Miles, the department decided that they would have this. Let's reduce our risks around lawsuits by having a robust process. They're saying they're going to celebrate on January 12th this whole new design, but the reality is I work at NAMI. We're still getting the phone calls. We now have law enforcement saying we no longer respond to mental health emergencies. So managing expectations is really important. We have a so-called anyone, any place, anytime, but I haven't seen one job announcement go out, so I know that I'm going to start getting the calls again. I already got calls in Walnut Creek from family members who should sometime. In our design team, what we learned is law enforcement says they only want to they don't want this job either. They only want to go out when it's a gun involved or some other deadly weapon or a person's at risk of suicide. They know they shouldn't be doing this. So the managing the expectation part is not having counties have a celebration before they have all the pieces and have a false expectation for families and others who are making the call that they're going to come out and have all the right answers. And so I wrote an email saying, halt. So I appreciate what you said, and I can quote you versus me taking all the heat. That's what community and advocacy looks like. Thank you.
Thank you.
So in the wrap-up, thank you very much. In the wrap-up, I wanted to thank the panelists very much for the transfer of information. For those that we didn't get to in terms of the questions online, we will take care of those off-site and get those to you. I want to thank Otsuka and Sozosei. This is choices. You made the choice to do this. And it is going to take all of us. And it is the construct of a quilt. We're building a tapestry, and if you think about a quilt, there's one thread that goes through that quilt, and there's all the patches on it. But it takes time, and it really takes a strategy of looking at how do you want it to look? How do you want that quilt to look? And that's what we're doing right here. But Sozosei and Otsuka made a choice to do this, and we want to thank them for that. The last thing I would say to you is it's, a place to call, 24/7 call center, someone to respond, peer representation on that triage team, and a place to take them, crisis stabilization centers. I'd ask you to do the audit in your communities of what centers that you have in your communities and look at that gap. There's a lot of real estate that's available. There's a lot of brick and mortar that's available in these communities. What are we doing to challenge our communities to take that brick and mortar and make it crisis stabilization centers? Lastly, I'll close with this. Knowledge allows us to do by choice what others do by constraint of fear. The knowledge and the fear are both great motivators. Let the knowledge that's being shared this week empower what we do, and let the fear of what could be the outcome from another family keep us going when we get tired and motivate us to continue to work together. Thank you for this opportunity, and we wish you the best over these next 3 days.
Well, I'll join in the gratitude for that amazing panel. Thank you all so much. That was really terrific. Thank you. We now have another break. We have some wonderful snacks upstairs as well as outside. I encourage you to go take a moment, stand by the windows, get some light, and get some art in your system. Upstairs, we'll be coming back with our next panel in about 15 minutes. Thank you.